This conference will now be recorded.
Okay. So coming to the definition, when you call it as post-term pregnancy, it is completed more than 42 completed weeks, and in days count, you take it as more than 294 days. And coming to the incidence of this post-term pregnancy is 4 to 14% of the total pregnancies. If you take only by LMP, you ask the LMP of the patient and you calculate with the help of your Neglis formula, then you will get a 7.5% incidence of these post-term pregnancies. With dating scan is more accurate compared to LMP. Patient may not remember exactly her LMP. So based on your dating scan and ultrasonography, you will get a lesser incidence of 2.6%. And if you combine both LMP and ultrasonography, you will get still more accurate, and the incidence of this post-term pregnancy will be 1.1%. So, like if a girl is having preterm delivery in her first pregnancy, in her successive consequent pregnancies also she is likely to be preterm. Similarly, if she's postterm in her first pregnancy or previous pregnancies, and this pregnancy, if she had one postterm previously, now there is likely she's going to be postterm again 27%. If she has history of 2 postterm pregnancies, this time she's likely to be postterm again 39%. So this is about the incidence of postterm pregnancy. So what can be the causes? Whenever you calculate the gestational age and you get like 42 weeks or 43 weeks, immediately you have to recheck the dates. So wrong dates is the most common and the first to be ruled out in case of these post-term pregnancies. So wrong dates due to inaccurate LMP, she might not be remembering, or you can provoke her like asking in relation to some festivals. So you can recheck the LMP, last menstrual period of the patient, and if she's on any method of contraception like oral pills, or if she is in lactational amenorrhea, she might not be getting her cycle, or the cycles might be irregular, and now she's she might be pregnant with lactational amenorrhea. Then also you won't get an exact LMP. Or if there is biological variability, it can be hereditary also. If the mother is having some this post-term history, it can repeat with this girl also now. And there are some maternal factors like irregular ovulation. So when we see this irregular ovulation, like in case of PCOD, if the girl is having cycles every 2 months or 3 months, but you calculated your gestational age with the help of Neglis formula, but which is fit only for regular 28 day or 30-day cycle, then also you cannot exactly predict when her ovulation is, and you cannot predict the ovulation when she is on some contraception or when she is in lactation also. You cannot exactly predict the ovulation. Normally when ovulation occurs exactly 14 days before the onset of next cycle. So here in these conditions, when the ovulation is irregular, we cannot predict and we cannot rely on our Neglis formula. And primiparity. Primiparous also tend to be having post-term dates. And elderly multiparate, when her age is more, then also. And the decreased fetal estrogen production, placental sulfatase deficiency, anencephaly, or fetal adrenal hypoplasia, which is causing decreased cortisone response. Because these hormones and cortisone, these are responsible for initiation of labor. When the patient is in term, these are the ones which take the active part in the start of labor, initiation of labor. Because of absence of these sulfatase and decreased estrogen production, then there will be no onset of labor and they are likely to be crossing 40 weeks of gestation. And very, very rare is extrauterine pregnancy. What do you mean by extrauterine pregnancy? That is ectopic pregnancy. So outside the uterus means it can be cervical pregnancy or tubal pregnancy, which is most common, or ovarian pregnancy. Most of the times, if it is extrauterine pregnancy, as it grows like maximum up to 8 to 10 weeks, or rarely 12 to 16 weeks, then we will get the diagnosis of extrauterine pregnancy or rupture ectopic pregnancy. That will be an emergency. Very, very rarely an abdominal pregnancy, that too progressing towards term and no labor, going into post dates. That is just theoretical set, very, very rare condition. And how will you diagnose this post-term pregnancy? First of all, the three important to be ruled out are: first, recheck the date of LMP, and you can ask for date of ultrasound dating when her first scan was done, because the first scan uh, where the which gives the crown rump length is more comparable and more accurate with the gestational age. And you can ask about the timing of intercourse also. With the help of it, you can calculate the expected date of delivery. So, and you can ask about the menstrual history also, because if her cycles are regular only, we can calculate exactly. If her cycles are irregular or delayed cycles, then we have to rely again on the early ultrasound. So this is about diagnosis. How will you see clinically? You can ask for the weight record of the patient. Every time she goes into the hospital, she will have a weight record. So you can check the weight records, and you can check the abdomen girth also. So what happens is, after 40 weeks of gestation, there will be the amniotic fluid, liquor will be decreasing in amount. Thereby, the girth of the abdomen also gradually decreases. And you can ask about the history of false pains also. False pains are nothing but there are something called true pains and false pains. True pains are when the patient comes to term, she will start labor pains. The pains will start increasing in intensity, frequency, and it is associated with progressive cervical changes. But these false pains are irregular. Sometimes it will be too strong, sometimes it will be too light, and there won't be any regular periodicity, and they don't increase with time also, and there are no cervical changes at all. So these are false pains. So most common cause for these false pains are loaded rectum. The patient might be because of progesterone and all, there will be incomplete bowel emptying. The rectum might be loaded, and she might be experiencing these false pains. So simple enema can relieve her from these false pains. You can ask about the history of false pains also. And on examination, palpate the abdomen. So first of all, when you examine an antenatal case, what will you see? Height of the uterus. So whether it is corresponding with that particular gestational age or not. And size of the fetus. You can make out when whether the baby is small or big compared, like term baby, or baby is too big compared to post-term. And hardness of the skull bones. The preterm head will be softer compared to a term head, and the post-term head will be still more harder. So you can compare the hardness of the skull bones also, and palpation. And here the uterus will be full of fetus. So I told there will be decrease in the amount of liquor after 40 weeks of gestation. What happens? The amniotic fluid is less, means when you palpate the abdomen, you will feel like it is full of fetus. The fetal parts will be very much palpable, and this feature is associated with post maturity. So similarly, you can see like this in case of oligohydramnios. What is oligohydramnios? The amniotic fluid is lesser in amount. Polyhydramnios is more in amount. So AFI, you take it as 5 to 25 as cutoff. More than 25, you consider polyhydramnios. If the amniotic fluid is too high, there will be tense abdomen, and you cannot clearly make out what are the fetal parts, and you cannot clearly make out the position of the baby also. But if it is a case of oligohydramnios, the amniotic fluid is very less, then also you can feel like full of fetal parts, easily palpable fetal parts. Okay. Here also in postterm, as the amniotic fluid is going to decrease now, you can clearly and easily palpate all the fetal parts. Next comes your PV, internal examination. And what you will check whether the cervix is ripe or not. Cervix is ripe means this is suggest to fetal maturity. Means she's already term or postterm, and the cervix is ripe and she's good to deliver. But there are few conditions where the cervix is unripe, but still the baby is mature. So ripening of the cervix, if it is positive, it is positive towards fetal maturity. If unripening of the cervix is there, still the baby can be mature, and you cannot completely exclude this postterm pregnancy. And if you do a PV, and if you feel the skull bones, if they are hard also, it suggests toward postterm pregnancy. And you have to confirm your diagnosis. What are the investigations? To confirm, first you have to confirm the baby is mature or not, to confirm the fetal maturity, and to detect if there is any placental insufficiency. So how will you assess for fetal maturity? Ultrasonography. So the first thing, when you examine clinically, you have a doubt about dates, you recheck it with LMP and all, then you have to confirm with the ultrasonography. So in ultrasound, you will go by the gestational age, and you will get the gestational age based on the ultrasound. Next, there is one more invasive method, that is amniocentesis. You take out the sample of amniotic fluid, invasive procedure, and check out the maturity of the baby. See, how will you determine fetal maturity? If you have doubt, the first and most important to determine the gestational age are recheck LMP, early ultrasonography, and the timing of intercourse. Then how can you assess clinically LMP when her fetal heart sound was auscultated at 17 to 20 weeks? Usually first time fetal heart sound auscultation will be there. If she has any recordings with her, you can check. Then fundal height. Next, feel of the head, harder or softer, and the amount of amniotic fluid, like and the cervical condition. This is clinically on per abdomen and PV examination. Coming to the investigation part, we have non-invasive and invasive things. Non-invasive is the most helping and the most commonly done is ultrasonography. If it's first trimester scan, what we see? Crown rump length, CRL. It is more accurate when combined with LMP compared to only LMP. Okay, CRL first trimester scan plus ultrasonography, LMP both are corresponding means it is sure of dates, and here plus or minus 5 days variation is acceptable. If you do an ultrasonography, crown rump length is corresponding to some 7 weeks, and by her date she is corresponding to like 7 weeks 2 days. So it is less than 5 days means, so you can go with the LMP. It is acceptable. In second trimester, what we see biparietal diameter and femur length. Here the variation of 7 to 10 days is acceptable. And third trimester, along with biparietal diameter and femur length, we will see head circumference and abdominal circumference as the baby still grows more here. And here a bit more variation, plus or minus 2 to 3 weeks is acceptable. Next, along with the baby parameters, you will check amniotic fluid index. In postpartum pregnancy, there is tendency towards decreasing in the amniotic fluid. This is about the scan, ultrasonography part. And we have one invasive thing also, which is not routinely practiced, that is amniocentesis. When you do amniocentesis and take out the sample of amniotic fluid, and there are few tests for fetal maturity, like you can see orange color cells, presence of phosphatidylglycerol, LS ratio, less than sphingomyelin ratio, and lamellar body count if it's more than 30,000 per microliter, and saturated phosphatidylcholine. These are all the indicators of fetal maturity. If they are present, the baby is said to be mature. Okay, so these are some ultrasound parameters. Crown rump length, you measure from the head to the buttocks of the small little baby in first trimester. Biparietal diameter is, that is the head between two parietal bones. Abdominal circumference, head circumference, and the femur length. As the I told, crown rump length is more accurate and more corresponding in case of first trimester. As the baby is growing, the femur length will be the more corresponding starting from the second trimester, more reliable fact. So how will you do antepartum fetal surveillance? The most common and important is fetal movement count. You call it as DFMC, daily fetal movement count. So you ask the patient to check for the fetal movements every day when she reaches term 34 plus weeks. You ask the patient after having each meal, breakfast, lunch, and dinner, for 1 hour, she has to lie down, put her hand on the abdomen, and she has to count the movements of the baby. A sum of these three means 1 hour after breakfast, 1 hour after lunch, and 1 hour after dinner. If you add all these three, it should be more than 12. If the baby is not moving those many times, or if it is less, you ask her to report immediately. Means there is some problem with the baby. So this is called DFMC, which we routinely advise to all term patients. Next, amniotic fluid assessment. You have to do it twice weekly. So how will you assess this amniotic fluid? This is again with the help of ultrasound. You divide the abdomen into 4 quadrants, Q1, Q2, Q3, Q4. And with the help of ultrasound probe, you will measure the deepest vertical pocket of the amniotic fluid in each quadrant, and you sum up all these 4, Q1 plus Q2 plus Q3 plus Q4. You call it as amniotic fluid index, AFI, and the normal range is 5 to 25. If it is less than 5, oligohydramnios. More than 25, it is polyhydramnios. Okay, and if AFI is less than 5, and that is oligohydramnios, or the single deepest vertical pocket is less than 2 centimeters also, you consider it as oligohydramnios. And next is NST. What is NST? Non-stress test. Means if you have seen in our labor room during our clinical postings, we have a machine called CTG, NST. We have a probe. First, with the help of stethoscope, you locate the fetal heart sound on the abdomen, and you will put the probe with a jelly applied on it on the on the location where you located the fetal heart rate, and also you will give a probe to the mother hand. With each fetal movement you ask her to press on it. So you will run a graph for 20 minutes. In 20 minutes you must have accelerations, you must not have decelerations, it should have a good variability. It is nothing but the fetal heart rate, how it is going on for 20 minutes, you will get a trace. So when you call it as reactive, NST is reactive or reassuring, means the baby is doing good, then uh, you can go for repeat of NST twice weekly. Or if it is high risk case, you can go for twice weekly, otherwise you can go for weekly once. Non-reactive means there is some problem or some with the baby. So to call an NST reactive, it should have 2 or more accelerations in a 20-minute period. It should not have any deceleration. What is acceleration? The fetal heart should be increasing 10 to 15 minutes more compared to baseline, and it has to sustain for 10 to 15 seconds. You must have 2 or more accelerations. Deceleration is similarly the 10 to 15 beats coming down, but that is not a good sign. And it should have a variability also. All the time baby should not have 140 fetal heart rate. So what is the normal range of baby fetal heart rate? 110 to 160. Below 110 is abnormal again. Above 160 is also abnormal again. So there will be variability. 5 to 20 beats of variability will also be there. So if possible, browse like NST graph and see the images. You will get an idea. So if 20 minutes NST is reactive, it implies that the baby is good. Next, if you have any doubt, you can go for biophysical profile. Biophysical profile is again ultrasound helped investigation. For 30 minutes we will do. Here we will do amniotic fluid index. Again NST is done. Along with it, you will check for baby breathing movements, fine movements, gross movements. So tone of the baby movements like breathing movements. These are all observed over a period of 30 minutes, and you will have a score of 10. The score is 8 or more. It is reactive. Less means you have to recheck again. We have one more thing called modified biophysical profile. Modified biophysical profile, which includes only NST and AFI. If NST is reactive and amniotic fluid index is good, your modified biophysical profile is also good. Next, if still we have the doubt, you can go for Doppler studies. So after birth of the baby, how will you diagnose post maturity? The baby looks thin and old. See the diagram. Skin will be wrinkled. There will be absence of bony scatiosa. The body part is greenish yellow color, and the head is hard without even the evidence of molding. Now, what is molding? During the labor, there will be slight overlapping of the skull bones to decrease the diameters during delivery. Here, as the bones are grown and hard, you can't find the evidence of molding. And the nails overgrown, including beyond the nail beds. The weight will be usually, as it's a big baby, more than 3 kgs, and the length is more than 54 centimeters. But sometimes, even if the baby is post mature, completed 42 weeks, but it can be an IUGR baby with a lesser age. This post maturity syndrome occurs in 20% of pregnancies. Newborn has dry peeling skin. It will be typical old man look, and it's coated with meconium. The hair and the nails will be overgrown. Nails will be beyond the nail beds, and there will be well developed armor and soles creases. There will be little or absent bony spaciosa, and the minimum subcutaneous fat with apprehensive look. So this indicates intrauterine the baby is facing malnourishment. Okay. So what happens to Lyca rhamni after 40 weeks of gestation? The amniotic fluid also starts decreasing. scanty. Most of the times it will be meconium stain. And the placenta, there will be aging of placenta, which is manifested by excessive infarctions and calcifications. What happens to umbilical cord? There will be decreased Wharton's jelly. Decreased Wharton's jelly again precipitates when the patient is in labor. With each contraction, there will be compression of the cord. So cord compression means again decrease in the oxygen to the baby. Baby having hypoxia and acidosis. So what are the complications? Fetal complications during pregnancy, there will be diminished placental function because there is placental aging, calcification. Baby won't be getting proper nutrients and oxygen like that of a good placenta, and the amniotic fluid will decrease, oligohydramnios. And if the baby is facing hypoxia or any fetal distress, meconium staining liquor will also be seen. This is during pregnancy. If during labor further aggravates hypoxia and acidosis, the labor won't be good like that of normal term labor because the baby is big, the more chance of disproportion and the more chance of delayed prolonged labor, the more chance of instrumental delivery like venous or forceps, and higher the cesarean section rates. And if the baby passes meconium inside the uterus, what happens? There is every chance of meconium aspiration and again atelectasis to the baby. And oligohydramnios, amniotic fluid is less and Wharton's jelly is also not there. There is risk of cord compression, again hypoxia to the baby. If it is a big baby, you deliver the head and there is every chance of shoulder dystocia. You will stuck up with the shoulder. If there is shoulder dystocia, we have some maneuvers to deliver shoulder dystocia baby. If you succeed in those maneuvers, you can deliver. Otherwise, we have to go for cesarean section again. So during our struggle also, the baby is like to have clavicular fracture, humerus fracture, and also nerve injuries, Erb's palsy, clunky palsy, and also the mother also, because of this much manipulation and instrumental delivery, can face bad perineal tears, okay, and more the amount of traumatic PPH and increased incidence of birth trauma because big baby and there won't be easy molding because due to hardening of the skull bones, and molding decreases the diameter and helps in the delivery of baby. But here the bones have grown harder and there won't be any molding. And there will be increased instance of operative delivery. So these are all the complications during labor. The main clinical significance of postpartum pregnancy is dysmaturity and macrosomia. So following birth, what happens to baby? If there is meconium aspiration into the lungs, there will be chemical pneumonitis, atelectasis, or even primary pulmonary hypertension. Then the baby develops hypoxia or even hypoxic ischemic encephalopathy and respiratory failure, hypoglycemia, polycythemia, and increased incidence of NICU admissions. So there will be higher the incidence of perinatal morbidity and mortality also. Starting from 37 to 43 weeks, this incidence will be higher. So this is meconium aspiration level. If the patient is having preterm labor, there won't be much problem with the mother. Mother won't have that much complications. Only we are concerned more about the baby because it's a smaller baby. It cannot substantiate like that of a term baby or higher the perinatal morbidity, mortality, NICU admissions, and infection rate. Everything will be higher with that of a preterm baby. But in case of post-term baby, both the baby and mother both are at risk. Here, the mother will be having more birth trauma and also baby is at risk. Okay. So what is meconium aspiration syndrome? If the meconium is passed, baby, if it faces hypoxia inside the uterus, it will pass the meconium. Meconium is nothing but the first stool passed by the baby when it passes after delivery. But if the baby faces unfavorable circumstances or hypoxia inside the abdomen itself, it passes the meconium. And if this meconium, what happens? It mixes up with the amniotic fluid. If this is swallowed by the baby. If it goes to the lungs during or immediately after labor, if the baby aspirates, there will be meconium aspiration syndrome. You can see in the diagram. So what happens? If there is aspiration, if there is mechanical obstruction, air trapping and uneven ventilation, hypoxia to the baby. If there is chemical inflammation or surfactant inactivation, again atelectasis and intrapulmonary shunting will be there. So finally the baby will be having hypoxia and primary pulmonary hypertension. So how will you manage? When the patient comes to you with regular checkups and all, You can advise her when to follow up. After 36 weeks, you can ask her to come to you every week, and you can warn about the signs and symptoms of labor and ask her to report to you if she feels anything. Otherwise, if the patient already came to you post-term, completed 41 or 42 weeks, she came to you, then how will you manage? There is two conditions called uncomplicated and complicated. Uncomplicated means there is no other obstetric complication except this post-term. So you can go for selective induction. The pregnancy can be allowed to continue till spontaneous induction. You will wait till the spontaneous labor, and meanwhile you will check for the fetal surveillance with the help of biophysical profile twice a week. This is selective induction. Otherwise, routine induction. After completion of her expected date of delivery, you will wait for 7 to 10 days. If she goes into labor, fine. Otherwise, we will start inducing with the help of medical methods and surgical methods. So this is what routinely practiced, routine induction. And next is complicated. Complicated means already having some other complications like elderly primary gravida, preeclampsia, RH incompatibility. RH pregnancy should not be allowed even till term. If the patient is having GDM or preeclampsia also, we will terminate them after completing 37 completed weeks. Because and oligohydramnios, all these cases, because if you still allow, there are chances of stillbirths and IUDs, intrauterine deaths. So you have to go for elective cesarean section in these cases. And if associated complications are likely to produce placental insufficiency also, you should not allow the pregnancy to go past it. You have to go for elective cesarean section. So fetal maturity, how will you assess? NST, amniotic fluid estimation, biophysical profile, and Doppler studies. And then by doing these investigations, you can come to know whether it is complicated or uncomplicated. Complicated and inclination towards cesarean section is if the cervix is not favorable, you can go to cesarean section as it is a complicated case. If the cervix is favorable means there are some cervical changes and she is likely to deliver, then you can go for ARM, artificial rupture of membranes, and you will check the color of the amniotic fluid. If the liquor is clear, you can go for oxytocin drip and expected vaginal delivery. If there is like a meconium stain, then you can go for continuous electronic fetal monitoring and amnio infusion of scalp pH, because these tests tell you how the baby is. If the baby is good, satisfactory behavior, you can allow for vaginal delivery. If the baby is acidotic, means the fetal heart rate or continuous NST, electronic fetal monitoring is not good, then go for cesarean section. This is about the complicated story. If it is an uncomplicated pregnancy, wait for 7 to 10 days. If she goes into labor, fine. Otherwise, go for induction. If the cervix is ripe, go for stripping of the membranes, artificial rupture of membranes. If the cervix is unripe, administration of the most common cerviprine jelly for prostaglandin E2 gel every 6th hourly. Next, the cervix ripens. Next, go for ARM, amniotic fluid color you see. If it is clear, oxytocin drip and expected vaginal delivery. If it is not clear, meconium staining is there. Then again assess the baby with the help of continuous fetal monitoring and scalp pH. Scalp pH is not routinely done. If the baby behavior is good, fetal heart, everything is good, allow for vaginal delivery. The baby is not good, acidosis or distress or some problem with the baby, you have to go for cesarean section. Okay, this is about post maturity. హలో అయిపోయిందా అటెండెన్స్ సరే నువ్వు ఓకే అంటే నేను ఎండ్ చేస్తాను. ఓకే ఫైన్, లక్ష్మికి ఇచ్చేసేయండి. ఓకే స్టూడెంట్స్, థ్యాంక్ యూ, యూ కెన్ లీవ్.